Rajesh Sinha to be on the desk, please. He is a panelist with us and is a professor at RP Center.
Good morning, everyone. At the outset, I would like to thank the organizers of this conference for giving me this opportunity, particularly Elvi sir. Because of him, I could visit Amritsar. So I would be speaking on role of Nepafenac in pain and inflammation management post-cataract surgery. So longitudinal aging study in India, wave 1, they found that the overall prevalence of cataract among the study population was 14.85%, and record cataract surgeries in India over more than 8 million successful surgeries are performed. So ocular inflammation is common following cataract surgery. Inflammation can cause post-operative pain, photophobia, if untreated, can lead to increased IOP, posterior capsular opacification, CME, and decreased visual acuity. So management of post-surgical pain and inflammation, corticosteroids and NSAIDs, they play the main role. Corticosteroids, its mechanism of action acts by blocking arachidonic acid release by inhibiting phospholipolysis A2, reducing the synthesis of prostaglandins, thromboxanes, and eicosanoids. NSAIDs inhibit prostaglandin release by blocking the cyclooxygenase enzyme that convert arachidonic acid to prostaglandins. So corticosteroids, although they are the gold standard, but they have some limitations because they have some adverse effects such as increased IOP, increased susceptibility to infection, and slow corneal wound healing. Prolonged use of steroids can lead to development of glaucoma, visual acuity defects, and loss of visual fields. So NSAIDs, they are safer alternatives to corticosteroids. Benefit of NSAIDs over corticosteroids: stabilization of IOP, provision of analgesia, reduction in the risk of secondary infections. NSAIDs are indispensable in post-cataract surgery management because they are used to manage inflammation, CME, and post-operative pain, provides optimal surgical outcomes in both routine and complex cataract procedures, maintains intraoperative mydriasis, and reduces both intra and post-operative ocular pain. So Nepafenac, which is used for pain and inflammation management post-cataract surgery, indications are for the treatment of pain and inflammation associated with cataract surgery. Mechanism of action is Nepafenac is a prodrug. It penetrates the cornea where the hydrolysis enzymes, which are present in vascularized intraocular tissues, they convert it into active molecule Amphenac. Amphenac inhibits prostaglandin H synthetase, that is cyclooxygenase enzyme that is involved in prostaglandin production. Dosage is 1 drop TID starting the day before surgery, on the day of surgery, and for 2 weeks post-operatively. Administer an extra dose 30 minutes to 1 hour 20 minutes before surgery. So Nepafenac is the prodrug NSAID formulation, and it is unique as it is not a free acid like other topical NSAIDs. Other topical NSAIDs, due to their water solubility, they have limited corneal epithelial permeability. Nepafenac, being an unionized drug, is readily absorbed across the cornea at higher tier pH levels, and the preservative bag which is used against it enhances corneal penetration and increases corneal absorptions. So Nepafenac 0.1% provides the higher cure rate and pain-free recovery. A study comparing Nepafenac 0.1% in reducing the incidence and severity of inflammation and pain following posterior chamber IOL implantation. The primary endpoint was percentage of patient cured of ocular inflammation at day 14. One arm received Nepafenac and the other arm received vehicle, and a cure was defined as aqueous cell score plus aqueous flare score 0. Patient was considered cured if they remained free of ocular inflammation at all subsequent visits. So Nepafenac 0.1% effectively prevented and treated inflammation and pain after cataract surgery with a higher cure rate and more patient pain-free at each post-operative visit from day 1 to day 14. So benefits of pre-operative administration of Nepafenac 0.1%. So this study evaluated the efficacy of pre-operative administration of topical Nepafenac 0.1% on anterior chamber flare following uneventful cataract surgery in healthy patient. Clinical outcome measures were best corrected visual acuity, intraocular pressure, retinal central foveal thickness, and aqueous flare. So the outcome was preoperative administration of topical Nepafenac 0.1% is safe and effective, significantly reducing inflammation in the early postoperative period, 1 month compared to the untreated group. So another study which evaluated the analgesic effect of Nepafenac. So in one arm, patient received Nepafenac 0.1% plus topical anesthesia. In the other arm, patient received placebo plus topical anesthesia, and the endpoint was patient pain perception. Patients were informed about the visual analog scale and verbal pain scale immediately after the surgery. So preoperative Nepafenac 0.1% can reduce pain and increase patient comfort during cataract surgery and is more effective than topical anesthesia alone. So combining Nepafenac with steroid, so it may be a better alternative to corticosteroids. So systemic review and meta-analysis showed that NSAIDs and combination treatment showed a lower incidence of CME. NSAIDs showed lower central macular thickness. NSAIDs had favorable flare values, and combination treatment showed favorable best corrected visual acuity. So both NSAIDs alone and NSAID steroid combination treatments are more effective and safer than corticosteroids alone for the post-cataract surgery management. So addition of Nepafenac to dexamethasone enhances anti-inflammatory effect. So this study compared Nepafenac plus dexamethasone in one arm and dexamethasone plus placebo in another arm. And statistically, a significantly higher number of patients in the Nepafenac group reported being pain-free during the day after surgery than the control group. So number and percentage of patients with macular swelling of more than 10 micron were evaluated 3 weeks and 6 weeks post-operatively. Nepafenac group had less macular swelling than the control group, and the differences were statistically significant for primary and secondary outcome measures. A higher percentage of patients in the Nepafenac group than in the control group reported having no ocular discomfort or photophobia 1 day and 3 weeks post-operatively. So combination of Nepafenac and dexamethasone reduces subclinical macular swelling and inflammation along with subjective complaints, suggesting it is an effective anti-inflammatory regimen following cataract surgery. So combining Nepafenac with prednisolone again is more effective in controlling ocular inflammation than prednisolone alone after emulsification. So this group had group 1 which received prednisolone 1% and the group 2 which received Nepafenac and prednisolone 1%, and clinical outcome parameters were anterior segment inflammation and CME. So addition of Nepafenac to prednisolone significantly reduces intraocular inflammation more than prednisolone alone after phacoemulsification in the early post-operative period. So main takeaways are Nepafenac, an unionized drug, is readily absorbed across the cornea at higher TRPH levels. It also contains BAK, a corneal permeability enhancer, as a preservative. Nepafenac prevents post-cataract surgery inflammation and pain with a higher cure rate and more patients being pain-free. Pre-operative Nepafenac significantly reduces inflammation in the early post-operative period compared to the untreated group. Pre-operative administration can also reduce pain and increase patient comfort during cataract surgery. Combination of Nepafenac and dexamethasone reduces subclinical macular swelling and inflammation along with subjective complaints. Addition of Nepafenac to corticosteroid significantly reduces intraocular inflammation compared to prednisolone alone after phacoemulsification surgery. Thank you.
Thank you, Dr. Prateek. I would like to know from the audience, is there anybody who is not using anti-inflammatory perioperatively? Do all of you use anti-inflammatory perioperatively? Dr. NK? So is there anybody who is not using, if not using for any reason for that?
So, yes.
Prateek, I think he has a point, because if you see the inflammation ka cascade, steroids act at a very high level,
Yes, at a higher level, yes.
and COX inhibitors act at a lower level. So अगर ऊपर ही बंद कर देंगे तो नीचे का जरूरत नहीं होना चाहिए.
Some inflammation goes down, so they will control part, and the Nepafenac or NSAID, they will further block the prostaglandin
So
release.
these are slightly loose words that some inflammation goes down, some का मतलब 5%. What I am trying to say is that you see, most of us used to do steroids first, After 2 weeks, once we are tapering and reducing and stopping, add Nepafenac to take care of the because the advantage is that it takes care of the prevention of CME also.
So a study conducted in Europe, they found that adding NSAIDs post-operatively for 2 weeks reduces the incidence of CME, particularly in diabetic patients. So in those cases, it is mandatory. Plus, you can increase the patient comfort, as I showed in studies.
Let's ask Hemlata, what do you say?
So there's so many studies that show that the combined use of non-steroidal anti-inflammatory with steroid have more efficacy in reducing the macular edema incidence of.
Plus, nowadays we are doing a lot of femto surgery, so adding pre-operatively and before surgery will prevent the intraoperative meiosis also,
Meiosis
sir.
also.
Because after femto, we see that many cases they come with 2 mm pupil size. So if you start pre-operatively NSAIDs.
What is your take on 0.1%, 0.3%?
Yes,
OD
sir.
dose is more
So
compliant.
both are effective, but it has been found in studies that 0.3% gives more comfort, more anti-inflammatory effect, and less lid swelling at the end of 1 week post-surgery compared to 0.1%.
No, before Harbanslal Panchi said, Rajesh, what is your take? What is your routine?
I feel that, based on the literature and based on our own experience, I feel that NSAIDs may not be required in all the cases, but in high-risk cases like cases of healed uveitis, patients of diabetes, patients who had a PCR, patients who had complicated, prolonged surgeries. In all these cases, I think addition of NSAID Nepafenac is very useful.
So you don't give in routine cataract surgery?
Not in all cases, but yes, in all these high-risk cases, yes, I do add. Additionally, if I'm using low-potency steroid, there are some patients who are steroid responders, or in some of the myopes wherein I don't want to take a chance. So I do give low-potency steroid. Therein, I add once daily high concentration Nepafenac.
So do you use this pre-operative non-steroidal in all the high-risk patients?
Yes.
And how many weeks prior to the surgery you start?
3 days before. Actually,
3 days.
Ideally you can start a week before, but 3 days is good enough.
You prefer 0.3 or 1.3 if you start 3 days prior?
See,
and which one is better?
If you're using 0.1, you can use it 3 times a day. So being a cornea person, I would prefer putting once daily because it will have less surface toxicity. So once daily is preferable as far as I am concerned.
So that's why my next question for Dr. Prateek. He's a cornea person. So how friendly are these drugs for the cornea? Because I've seen a lot of patients developing SPKs post.
So what I have noticed is with the Nepafenac and Ilevro, compared to the generics, they are more cornea friendly. Generics, they cause more SPKs, maybe the formulation is different, or maybe the method of preparation is different. But Nepafenac and Ilevro, I have not found any corneal toxicities. And we have to be careful in patients who have very severe dry eyes.
Quite a confusing situation now.
Yes.
So you have to punch it now. You have to
So
tell
I
what
think
is
that's a very difficult proposition to keep on changing the medication from one patient to another patient, because this medication is explained by our staff. And it's better to have a standard medication protocol for first few days. That means when the patient is operated and you see next day or 2-3 days, and then you can stop it or you can prolong it. Because if some patient you are giving, some patient you are not giving, this stop is going to be totally confused. So my protocol will be standard for all of them. Get the Nepafenac for 1 week, and there is absolutely no inflammation. And if there are any signs of SPKs developing over there or dryness developing over there, or there are symptoms of the dryness, then of course I will try to stop most of the medication as early as possible. So this is very difficult to keep on changing the medication. So the standard protocol is that all of them get it for 1 week, and then if required we can prolong it or shorten it.
So my question to Dr. Namta is, in which cases you will avoid Nepafenac post-cataract surgery?
So cases of dry eye, I would
Yes.
avoid. Cases where I fear that there might be compromised ocular surface, like Steven Johnson, ocular cicatricial pemphigoid, those cases I will not give NSAIDs at all.
With corneal scars also, ma'am.
With corneal, wherever there is any
So any
corneal or
corneal-
ocular
any
surface
corneal
pathology,
any corneal
yeah,
pathology,
so
dry
there
eye,
I
you
will
should-
not give Nepafenac.
So I think this is a very good message Namrata has given. And
Any ocular surface disorder and any patient with a significant MGD who has a risk of, ocular surface disorder and SPKs, it should definitely be
So
avoided.
ocular surface disease, any corneal or ocular surface related problem,
Yes.
which would include everything.